Somewhere between 10 and 40% of adults over 40 in this country are living with nerve damage in their feet and don't fully know it. Some feel it as burning, some as tingling, that pins and needle sensation that starts at the toes. Others feel nothing at all. That absence of sensation is actually the most serious presentation because it doesn't indicate recovery. It means the nerves have stopped transmitting. Peripheral neuropathy is the clinical term for nerve damage outside the brain and spinal cord. It almost always shows up first in the feet. According to a 2024 cross-sectional study, it affects 14.6% of the general adult population. Past age 70, prevalence rises to between 26 and 39%. In a room of 10 people over 70, 3 to 5 of them statistically have this condition right now. In the United States alone, an estimated 13.2 million people are living with diabetic peripheral neuropathy, more than the entire population of Pennsylvania. And that's only the diabetic form. The total number across all causes is considerably higher. This video covers 3 exercises with documented clinical support for reducing neuropathy symptoms. They can be done at home without equipment and without a prescription. Before reaching them, it helps to understand what is physically happening to the nerves because the mechanism explains why these specific movements work. Peripheral nerves are the transmission lines running from the spinal cord to the feet, legs, and hands. They carry 2 types of signals. Sensory signals travel from the body to the brain, registering heat, pressure, and surface changes underfoot. Motor signals travel the other direction, directing muscle movement, foot placement, and balance adjustments. When these nerves are damaged, both functions decline. Sensation becomes unreliable or absent. Motor responses slow down. The result is a measurable and documented increase in fall risk. A study published in the Journal of the Peripheral Nervous System in December 2024 identified peripheral neuropathy as an independent risk factor for falls in older adults, not just associated with falling, but independently causative. A separate analysis of more than 21,000 hospitalized patients found that among 13 fall risk factors examined, chemotherapy-induced neuropathy carried the highest odds ratio, 3.4 times the fall risk of patients without it. The most common cause of peripheral neuropathy is diabetes. According to the NIH, diabetic neuropathy develops in approximately half of all individuals with chronic type 1 or type 2 diabetes. Elevated blood glucose over time damages the small blood vessels that supply oxygen to the peripheral nerves, gradually cutting off what the nerves need to function. More than 38 million Americans have diabetes, and an estimated 13.5 million of them are 65 or older. There's also a documented interaction between metformin, the most commonly prescribed medication for type 2 diabetes, and neuropathy progression. Research shows prolonged metformin use is associated with an 11.16% increase in vitamin B12 deficiency. In the same study, the prevalence of clinical neuropathy in the metformin-exposed group was 45% compared to 31.8% in those not taking it. B12 is essential for healthy nerve function. Patients on long-term metformin should have B12 levels checked regularly. Alcohol is another significant cause, affecting an estimated 10 to 50% of individuals with chronic heavy use. Chemotherapy accounts for a substantial share as well. 68% of patients develop neuropathy within the first month of treatment, and in survivors, it persists in 47% even 6 years later. Standard medications for neuropathic pain, duloxetine and pregabalin, provide meaningful relief in only 30 to 50% of patients. 77% of those prescribed these drugs stopped taking them within a year because of side effects. Between 2020 and 2024, the FDA approved 8 new treatments for painful diabetic neuropathy. 7 of the 8 are medical devices, not pills, a pattern that reflects growing limitations of the oral medication approach. The clinical case for exercise centers primarily on circulation. When peripheral nerves are damaged, the blood vessels supplying them deteriorate. Nerves deprived of adequate blood flow malfunction and eventually stop signaling. Aerobic exercise, walking, cycling, swimming, increases blood flow into peripheral vessels, delivering oxygen directly to the nerve tissue that needs it most. A 2006 study by Balducci and colleagues followed patients with diabetes through 4 years of aerobic exercise training and compared them to a control group that did not exercise. In the exercise group, 0% developed motor nerve dysfunction. In the control group, 17% did. For sensory dysfunction, the type responsible for tingling and numbness, 6% of the exercise group was affected versus 30% of the control group. That research has been in the published literature for nearly 20 years. Exercise also stimulates the release of brain-derived neurotrophic factor, a protein involved in nerve fiber maintenance and regeneration. Animal studies with peripheral nerve injuries show that exercise produced significantly faster nerve conduction in repaired tissue compared to sedentary controls. Exercise additionally triggers endorphin release, which provides pain relief through the body's own regulatory system without the side effects of pharmaceutical intervention. Clinical reviews confirm that simple foot exercises performed 3 times per week for 8 weeks reduced pain intensity in neuropathy patients, with improvements still measurable at 16 weeks. The Foundation for Peripheral Neuropathy recommends approximately 30 minutes of aerobic activity per day, 3 to 5 days per week. The 3 exercises below are drawn from physical therapy protocols and published clinical studies. Each addresses a different aspect of the condition. All should be reviewed with a physician before starting, particularly for patients with significant sensory loss, where reduced feedback increases the risk of undetected injury. The first exercise is the calf raise. Stand behind a sturdy chair with both hands on the back for stability. Rise slowly onto the toes, lifting the heels fully off the floor, and hold for 3 to 5 seconds. Lower back down with control. Start with 10 repetitions and build toward 3 sets of 10 to 15, 2 to 3 times per day. The calf muscles function as a secondary circulatory pump. Each contraction compresses the veins in the lower leg, pushing blood back toward the heart and drawing fresh, oxygenated blood down into the feet. For patients with diabetic neuropathy, where circulation to the feet is already impaired, this is a direct mechanical intervention. Beyond circulation, the ankle stability required to perform a calf raise engages the neuromuscular pathway between the foot and the brain, a connection that neuropathy degrades over time, repeating the movement exercises that damaged pathway. A 12-week foot and ankle exercise program that included calf raises demonstrated improvements over usual care in gait speed, ankle range of motion, vibration sensitivity, and quality of life in patients with diabetic neuropathy. That protocol is formally registered on clinicaltrials.gov. For patients with significant balance problems, a seated version, rising onto the toes from a chair with feet flat on the floor, retains the neuromuscular benefit at lower risk. The second exercise is ankle circles. Seated in a chair, lift one foot slightly off the floor and rotate the ankle in a full circle. 10 rotations in one direction, 10 in the other. Switch feet. Repeat 2 to 3 times per day. The movement takes under 3 minutes. Peripheral neuropathy reduces the neuromuscular responsiveness of the ankle. Signals coordinating ankle movement become degraded, and the joint progressively loses its functional range as brain-foot communication weakens. Ankle circles move the joint through its complete arc, generating continuous feedback through whatever functional nerve tissue remains. Physical therapists specializing in neuropathy consistently recommend this exercise as an accessible starting point for patients in active pain. The load is low enough to perform during a symptomatic period while still producing measurable benefit to joint mobility and circulation. The third exercise is toe curls. Seated with feet flat on the floor, spread the toes as wide as possible and hold for 2 to 3 seconds. Then, curl them downward firmly and hold again. Perform 10 to 15 repetitions per foot several times throughout the day. A common progression involves placing a small towel on the floor and pulling it forward using only the toes. An alternative uses marbles, picked up with the toes and transferred to a container. Neuropathy causes atrophy of the intrinsic muscles of the foot, the small muscles that control toe spread, grip, and weight distribution. As these muscles weaken, the foot loses its ability to grip surfaces and respond to uneven terrain. That instability, combined with impaired sensation, is a primary mechanism behind neuropathy-related falls. Toe curls directly counter this deterioration. Because the toes contain a high density of sensory nerve endings, voluntary toe movement also generates neurological input through remaining functional tissue, maintaining the feedback loop between the foot and the brain. A 12-week protocol combining toe curls, toe spreads, calf raises, and ankle work is formally registered on clinicaltrials.gov as an intervention for diabetic polyneuropathy, measuring outcomes in pain, foot and ankle function, and quality of life. Taken together, these 3 exercises target 3 distinct mechanisms. Calf raises address circulation, ankle circles address joint mobility and nerve signaling, and toe curls address intrinsic muscle integrity. None require equipment. 2 can be performed while seated. The research consistently shows that consistency matters more than intensity. Moderate exercise maintained over 8 to 12 weeks produces measurable improvements in pain, nerve function, gait speed, and vibration sensitivity. Studies also show that people who exercise regularly experience a slower rate of neuropathy progression compared to those who do not, meaning the condition advances more slowly in patients who maintain regular movement. The annual cost of diabetic peripheral neuropathy in the United States is estimated at $45.9 billion, according to a 2025 study in the journal Endocrine. More than $26 billion of that comes from hospitalizations, most of them tracing back to complications that begin with unmanaged nerve damage, foot ulcers, infections, falls, and amputations. The per-patient annual cost of those hospitalizations alone averages approximately $3,400. For patients with significant sensory loss, those who cannot reliably feel the floor underfoot, a few precautions apply. Exercise in well-lit spaces. Use supportive footwear rather than socks on smooth flooring. Keep a hand on a chair, wall, or counter during standing movements. Reduced sensation means injuries during exercise may go unnoticed. A controlled environment and deliberate attention compensate for impaired feedback. If pain worsens substantially or joint swelling develops, that warrants medical consultation before continuing. Patients on long-term metformin, those with a history of heavy alcohol use, anyone who has undergone chemotherapy, or adults over 60 should ask their physician about B12 testing. The neurological presentation of B12 deficiency is clinically indistinguishable from diabetic neuropathy. A standard blood test identifies it. Some patients have been managed for the wrong underlying cause for years before the deficiency was caught. The evidence supporting these exercises has been in peer-reviewed literature since at least 2006. The Balducci study alone, 0% motor nerve dysfunction in the exercise group versus 17% in controls, represents nearly 20 years of available data. 3 exercises, no equipment, no prescription, no cost. The research exists. The only variable is whether it gets put to use.